We are now live on Facebook.
Thank you all so much for sticking with us. So using a reproductive justice lens, obstetrics and gynecology serves as an illuminating discipline through which we can refract our most pressing crises: violence, health, and autonomy, and their disparate distribution along lines of gender, race, and class. Who is remembered? Who is erased? Say her name. Black women in the United States are 3 to 4 times more likely than white women to die during pregnancy or from childbirth-related causes. The CDC estimates that the majority of these deaths are preventable. Texas has one of the worst mortality rates in the developed world. Before we begin, join us for...
Okay.
Before we begin, please join us for a moment of silence for mothers lost, both named and unnamed.
Hey, this is Iris. We're not live on Facebook right now. Alia and Diana are suggesting that we just record and upload this on Facebook since we keep having issues. I don't know if you've seen that in the Slack, but Alia and Diana are flagging. And I can't seem to log back on. This is Iris, by the way. I can't log back on through my account.
We are live on Facebook.
It is live.
It's still live. Katie, can you go ahead and introduce our panelists?
Why can't I hear though? I can't hear anything.
Katie, we can hear you. It's your turn to introduce the panelists.
Thank you for joining us in that moment of silence. We're now going to go ahead and begin introducing our panelists, starting with Afua. Take it away.
Okay, my name is Afua Hassan. I am a midwife here in Houston, Texas. I'm originally from New Haven, Connecticut, and I have 4 children. They were all born at home, and all of them are breastfed. So presently I do, I have a birth center. That's where I do most of the births, but I do at least, well, 1 home birth a month. And this is my 37th year.
Thank you so much.
Okay,
Thank
great.
you so much, Afua. We're going to move on to Jen Sarduy.
Hi, I'm Jen Sarduy. I use they or she pronouns, and I'm the co-founder of Re+Birth Equity Alliance. We are inspiring, protecting, and building community with Black and Indigenous people of color and lesbian, gay, bisexual, transgender, and non-conforming people and their bodies. We do that through like a variety of things. We do a mobile mental health clinic, which is a quarterly pop-up virtual therapy for individuals, groups, and music therapy. We do Carnal Knowledge, which is community-based sex ed beyond like banana condoms. We do Tested and Rested, which is in response to our local public health department cutting off pop-up testing for COVID. We partnered with our local harm reduction coalition or harm reduction organization, ODAID, to provide free pop-up HIV and Hep C screening, pregnancy screens, menstrual supplies, harm reduction supplies, contraceptives, Plan B. And we do that in combination with a DJ, tarot reading, zines, and all kinds of cool stuff. We do Thrive, which is parenting workshops beyond survival mode, like barbering basics and music therapy. And we also train clinicians and care workers across that country on systemic racism in perinatal health.
Katie, you're on mute.
Thank you so much, Jen. We appreciate you. Next up, we have Dr. Jordan Wondrack.
Hello, I'm not a doctor yet. My name is Jordan Wondrack Beatty. Before I begin, I just want to acknowledge that this is a conversation about racism and I'm a white woman taking up space. So I'm really, honored to be here, and I am a cultural anthropologist. So what I can bring to the conversation is an understanding of systemic racism and how that impacts health. And that's what I study. And so my research looks particularly at anti-Muslim racism and how that affects health for Muslims living in the United Kingdom. And I teach a course at SMU on health as a human right. And I believe very strongly in that. And a huge aspect of that, of course, is reproductive justice. So I try to, instill that appreciation for that into my students, and really excited to be here tonight.
Thank you, Jordan. And I'm so sorry about that mistake on your title. I'm just excited for you to grow in your education. Next up, we have Asmara Gebre. Take it away, Asmara.
Thank you. It's Asmara Gebre, and I am a Black and Latinx midwife in San Francisco. I'm currently faculty at Ucsf in the School of Medicine, Obstetrics and Gynecology department. I founded BIPOC-aspiring Midwives in 2018, which is a shadowing, mentoring, and community building pilot program with a mission of supporting BIPOC individuals on their journey to midwifery education. I was recently named the first midwife to receive UCSF's Watson Scholarship, which will provide administrative time for me to expand the program. During COVID, I started One Love Black Mamas in San Francisco, working closely with Black identifying colleagues and community leaders to support Black community. Since April 25th, we have been going out to community weekly, giving out $200 cash and other resources for individuals who access reproductive health services. No questions asked or strings attached. We have now served over 100 mamas. I also started raising money for Black student midwives. I have now transferred $200 to each of over 150 Black student midwives through Venmo. Again, no questions asked, strings attached. My clinical practice for the last 2 years has been at San Francisco General Hospital, where I'm the only Black identifying midwife who provides prenatal care, continuity care to Black families, and the only public and sanctuary hospital in the city. On July 8th, I went on strike from clinical work after experiencing trauma with the sheriffs at the hospital. I'm sick of their racism. Less than 1% of hospitals in the United States use cops as their primary security for safety. And there's substantial evidence supporting effective alternatives. Cops have been proven to cause harm, and I'm demanding that the San Francisco Department of Public Health and the hospital divest from harm and invest in true safety for all, not just some. We belong in our hospital spaces. We belong in spaces to receive care. And we deserve to heal in spaces that don't cause harm. I refuse to go back until the sheriffs are out. Our community deserves true safety.
Thank you so much for those powerful words, Asmara, and sharing a piece of your story with us. Finally, to introduce, I have Francesca Austin right here from Planned Parenthood with us.
Hi, and good evening, everyone. So my name is Francesca Austin, pronouns she, her, and I'm a community health educator and outreach specialist for Planned Parenthood Greater Texas. I've been at Planned Parenthood Greater Texas for about 5 years now, and I've been a health education specialist a little longer than that. I really can't remember. It feels like an eternity, but I'm just happy to be sharing this space with these individuals who care so passionately about this work as well as I do.
Thank you, Francesca. We're excited to have all of you here. Thank you so much for taking a little bit of time out of your days. I'm gonna go ahead and get us kicked off, get the panel started. So we're excited to hear what else you have to share with us. I am one of the fellows who helped to plan the event. My name is Katie. I use she, her pronouns, and I'm here from Arlington, Texas. So to start us off with our first question, here we go. The history of sexual and reproductive health often serves as an acute reflection of the cultural values and politics of a given time period. How do you think the challenges faced in obstetrics and gynecology in Texas reflect the current landscape? And what changes would you like to see?
Afua, you're
Okay,
muted.
okay. I think that women need to educate themselves. And I don't like blaming the victim because that's not what I'm doing. But most women go to the hospital, have a baby, and they have no clue of what that system is. And so if they educate themselves to find out what it is, it's one thing to say, oh yeah, I don't want any intervention, but it's another to know what the interventions can possibly be. And like the woman Asia, she went in for an induction. Clearly her baby wasn't ready to come out. And so if she had said no, if she knew, no, it's not enough time, let me go into labor by myself, that might not have happened. And once again, I'm not blaming the victim, but it's one thing to want to fight the system. It's another thing to know what the system is and say, okay, I'm not taking part in that part of the system.
I think that something Hannah said earlier touched on this like topic for me. And I think that like when we think about the history of obstetrics, we have to remember like this system isn't broken. It's like functioning exactly the way that it's supposed to.
Correct.
And so when we're putting like the onus of like knowing that, like we're expecting Black birthing people to, and just like birthing people in general, to know a system that is stacked against them from the beginning. And like, we have to acknowledge that that is some like messed up stuff. Like that is a messed up system, and that's not okay. And it's also okay for us to like not buy into that, you know? And I think that that we keep us safe. And I think that that's what you're saying, Afua, is that like we've always been keeping us safe. You keep people in your community safe all the time by like sharing knowledge and, you know, providing community care. And I think that like continuing in the tradition of like us keeping us safe is one change that I'd like to see happen, you know? We work in such a way that like we feel like we owe our providers something, or they're our bosses. And it's important for us to remember that like quality healthcare is our right. Like we are owed healthcare, like it is, we need it in order to live. And it's okay for us to fire our clinicians if they are not serving us well. You know, it is okay for us to like to have questions. And I think that we're not taught that, you know, and yeah.
Yeah, that is a problem. That is definitely a problem, because in the state of Texas, doctors legally can just talk like, let's say their initial visit, 6 minutes. They can spend 6 minutes with a mom. And if that's all for your initial visit, so your return visit is 4 minutes. And women don't know that. They don't know the system that they're going into. And so when they come to my office, they come with a plethora of questions and a sad story in the hospital. And I ask, did you ask these questions to your healthcare provider in the hospital? And they say no. And so that's why it's important that we are able to educate the women. I used to teach a class how to navigate your hospital birth, and then people didn't want to pay for the class until after they had a hospital birth that they didn't like. And so I'm like, so what do I do as a healthcare provider? Because in only 1% of women are having their babies outside the hospital. And so I would love to be able to protect the majority of moms who go to the hospital.
Well, and I think outside of Texas, in many places, it really comes down to the systemic issues in hand. So regardless of where you are at, the amount of time each clinician is provided to spend time with each patient is very short, especially within an institution. So even if that person did have a list of questions prepared, their ability to access the time necessary to get those questions answered in a place where they can feel safe walking out of the institution is really rare. I think about my patient panel. I have patients scheduled every 15 minutes until I'm out the door. Realistically speaking, if someone has questions, I am going overtime. I get penalized for that time spent. I'm now backtracking. I'm now staying later. I'm now wasting potential financial resources. So the system is not set up in the best way to listen to Black birthing people, listen to people. And that's the systemic change that needs to happen. We need to center the voice of individuals, their experiences, their needs versus ours in institutions.
And for me, that comes from educating women to demand their time, to demand not being induced or augmented, because that's where the majority of women are going. And unfortunately, the system isn't even for white women. I mean, it gets us really badly, but it's not good for them either. And so when I make a presentation, I say it's not good for them too, because they really don't listen to when it's just about us. But when they realize they're dying and they shouldn't be dying at the numbers that they're dying, then they're like, oh, really?
And I think the piece too is access to alternatives. It's a person's choice where they birth, but if there's not options available, then what are they?
Correct.
Yeah, it seems like our system of medicine in the United States is so geared toward the physicians themselves. So how is it convenient for the physician to deliver the baby, not how is it best for the person giving birth? And how, for instance, like we're seeing all this movement toward cesarean sections, right? Because you can plan that and the doctor can decide, well, this is convenient in my schedule, not when is it best for the baby to be delivered. So these are really probably, artifacts of a capitalist system that wants to be efficient and have babies lined up and be as efficient as possible. And that's not necessarily what's best for the health of the person delivering. And so if we're able to speak back against that and speak out, which is very hard, I think that would be much better. But of course, there's unequal footing in the clinical setting between the doctor and the patient. The doctor has the power. So how do we become partners instead of the doctor having power over the person delivering?
And too, I'd like to also just give light to the fact that it can be an individual thing, like the person and the doctor, but it's also a systemic issue. There's even doctors within the hospital setting that are struggling to advocate for patient centered care when the system is set up to not be in that way. So more so than looking at the individual person coming in to receive care or that person providing care, let's look at leadership that's in charge of the system structure in place and how they are incorporating the true values of whatever institution's missions say that they are carrying out.
Thank y'all. Those are some really important things for us to consider. I'm going to go ahead and pass it over to my colleague Joanna for the next question.
Hi everyone, my name is Joanna. My pronouns are she, her, ella. I'm from the DFW area. And my second question is, what is the work your organization or you are doing to address systemic racism in the medical field?
Well, I'll go ahead and I'll start. I work at a Planned Parenthood affiliate, and I'm not a clinician, I'm not a provider, but I am a part of a community here in Waco, and we are, along with some other folks in the community, other organizations, we're partnering to help educate providers. Kind of like how Jen had mentioned what her organization is doing. We're doing something kind of similar. I would like to see Jen's work because it sounds awesome, and I would love to participate if I could. But we're helping them kind of structure like patient intake, right? What are some good questions that you can ask folks when they come in to see you, right? So you can make sure that their needs are getting met. So we have this tool is called the one key question. I might be messing up the name, right? But it's like, you go through and you ask them these straightforward, direct questions. Do you want to be pregnant? When do you want to get pregnant? What kind of birth control are you using, right? Like instead of using all this type of formulas and language that some of us don't understand when we're patients, and we're looking at it like, I don't know what the doctor asked me, but I think I'm gonna get whatever it was I told them I think I want based on the conversation. I'm not quite sure what they said, right? So we want people to kind of leave knowing that they've had direct conversations and there's an understandable language between the two of them. So there is some real communication. So that's something that we're working here on in our community to kind of help address those things.
I think you said my name and here I am. I think that, first of all, you can take our course. It's on our website on the events page. It's like donation based. And a lot of the things that we teach are things that you also mentioned, Francesca, which is like co-design and patient-centered care, like relationship-based care, right? People don't understand these forms. They're not meant for people. They're not meant to build a relationship. And that is the change that needs to happen in order to transform systems, right? We need to like have care based on relationship and not based on like capital. And as long as we like view birth as a transaction and view like care as a transaction, we're going to get transactional results. And so, yeah, we do a lot of like bias training based on like relationship-based care. And we also like center, all of our programs are run by like Black and Indigenous people of color and gender expansive folks. And yeah, we center the leadership of Black folks in our work, and not by tokenizing them, right? Not by just like putting Black folks on stage when we need somebody to like have a voice, by like giving Black folks like the leadership and the power and the dynamic, right? We talk so much about power dynamics, but when it really gets down to it, people would rather recreate organizing than like share organizing that's been done by Black people, you know? Like people would rather do anything than support like Black student midwives. Like if you're like, they're like, what can we do? They're always in my DMs, like, what can we do? Like, and I'm like, Cash App. And they're like, what can we do though? And so like, I don't know if y'all have that problem, but like, those are a few things I guess that I'm feeling tonight.
So what I do here in Houston is, you know, I'm a midwife and I give care, and I have created a community of moms and dads and babies through group prenatal pre-COVID, let's say that. So the third Sunday of every month, the moms would get together and I'd have food. And it was a potluck, so they would bring food also. We'd have a topic. Then we would share information. And every month, the moms would be advancing their pregnancy, and then they would come back and have their baby. And then they would share their birth stories. And it really helped when, you know, new moms are like, oh God, I'm up next. And then I had a dad's group, and the dads they didn't want to come. They were like, hey, it's football season. They always had an excuse not to come. But then when the wives made sure that they did come, they were so happy because it was a time that men got to talk about having babies, about being dads, about being husbands, about how their life changed, vasectomies, vaccinations. And all of it is very, very empowering because men generally aren't talking about, birth and especially vasectomies and vaccinations with other men. So we had breastfeeding. Once a month they would come from breastfeeding because a community is very, very important, and it is empowering. And even with the breastfeeding, it wasn't just the moms that were birth in place moms. Other moms would come too, because to breastfeed successfully, you need support. And when they would come when they were pregnant, they would ask questions, and we give them information so when they went to the hospital, they could be as strong as they possibly could be. But my prenatals last anywhere from 30 minutes to an hour. And some moms have to be here for an hour and a half because it's very important that they get all their questions answered so that when the day comes, they are empowered. And it's not over after the baby comes. It's, they still call after even the 6 weeks. They come by because my birth center is on the first floor and I live on the second. I get calls all the time. You home? And now, even with COVID, there were a bunch of moms out there today. They just met because they don't get to see each other and they miss. So as opposed to going out into the community and doing all the outreach, I do it right here at the birthing place.
I really appreciate the focus in centering community knowledge and giving space for that. I think oftentimes, and even in midwifery to a certain extent, I'm a certified nurse midwife, so that's a very that's a profession built on white supremacy that has a lot of those factors involved in how I was trained to think that safety and the right answer lies in the provider to a certain extent. And it's important for us to come to the realization that the people know what's best for them. And it is our job to support those conversations, facilitate space for that dialogue and that community wisdom sharing to continue on. It's been happening for ages. We don't need to come in and intervene. We just need to be supportive and support the process of dialogue, support the process of confidence, and share some safety nuggets along the way. So I think a big necessity is allowing for that space to occur. Oftentimes, people of color are isolated, whether it be in homes and in communities, in workspaces and education and all aspects of life. We're either isolated, or if we're put together in big enough groups, it's usually not in a great situation or in a safe environment or an equitable access to real safety. I think we could go into that, but we'll just leave that there. Yeah, we just need to center the people, give voice and power back to the people. And really learn in a new way, decolonize.
So my answer is a little bit different since I'm not an activist or a professional in this space, but rather a researcher. I look at how policies often are affecting are basically perpetuating racism, in a systemic and institutional way, and then how that's affecting health. And one of the clearest links we can see between systemic racism and health in literature is that we see low birth weight or we see preterm babies. And so this is sort of a shocking and horrifying thing that if a pregnant person is experiencing discrimination on any number of levels, that they're going to have a higher chance of delivering early or delivering a lower birth baby. And there's a really interesting study that was done actually right after 9/11, where they compared this, the 6 months after 9/11, they looked at women delivering babies who had names that sounded Arab. And then they compared that to babies delivered with Arab sounding names a year prior. And they found that the names that sounded Arab had, those families, their outcomes were worse right after 9/11. And they, in the discussion, they talk about how we suspect this has to do with the fact that people thought they were being viewed as a threat, or they were being viewed as a terrorist, or they were being viewed as an outsider. So we know that when someone is dealing with this sort of horrible feeling that they're being told you don't belong, or you are lesser, or you are a threat, that it's going to impact their pregnancy and going to impact their health. And so I think getting the word out about that, you know, having these conversations, this is sort of what we need to do and where we need to be going.
Thank you so much for everyone. I'm going to hand it off to Marissa for the next question.
Thank you, Joanna. I'm Marissa, and my pronouns are she and her, and I'm from Austin, Texas. Our third question is, how can we help? What can we do collectively to address these issues?
I think the number one thing is we all, if all, but are here in the United States of America. The United States of America was founded to do what it's meant to do, which is to support and thrive on white supremacy. And so until we all come into a common conversation at the dinner table with our children and neighbors, our educators, around racism is real, and have accountability to where we lie on that spectrum, it's really hard to move forward in solidarity around this work. Anti-racism is necessary. It's anti-racist or racist. You can't be in the middle. You got to pick a side. Most of us appreciate when you actually just are transparent with the side, because it makes it easier for us to navigate the world. So I'd say stop being a fence rider.
I would say, for me, donate to an African-American woman or a woman of color who's having a baby so she can find a midwife. But the issue of systemic racism is real because there are Caucasian midwives here that have acknowledged, you guys have drunk the Kool-Aid because all lives matter. And then nobody said anything until I said something on the thread. And so even getting that white midwife and doesn't necessarily mean that they're going to get quality care. Like they'll get midwifery care, but not with the understanding of the issues that we have. So what she's doing, support another African or woman of color to be a midwife, support midwifery. I mean, it's just, for me, the concept of racism is so huge, of trying to, for me, I'm not the person that's gonna try to knock it down. I'm gonna do my little part over here in terms of giving the best care that I can give. It's not that I don't want it knocked down, but you know, I chose midwifery the way I chose it because I graduated from Brown, that Ivy League institution. And when I went to go become a midwife, I said I wanted it from the ground up as opposed to top down. And so I totally understand like the issues that you have in the hospital, and I just didn't want to be there. So I did my little niche, you know, because that's what it is for me. And I think that everybody needs to find what they can do. If it's donate money, if it's talking about racism, if it is acknowledging that you're a racist, you know, or you say, oh, well, it's not me, but my granddad. When you hear it, do you say something? When they're sitting around at the dinner table telling jokes, do you say that's inappropriate? Because most people don't. They just, even when it feels bad to them, they're like, oh, I don't wanna rock the boat. And it is a huge problem that we have. And as African Americans, we are dying on all levels, not just healthcare, just walking down the street, and it's really scary. I mean, it is, and white people are like, oh, I didn't know it was like that. Like, yeah, and it didn't just happen. Like it didn't just happen. It's been going. So I applaud everybody doing the thing that they are comfortable doing, or even when it's uncomfortable, but they're still doing it, because racism is a big, big monster in the middle of the room.
I agree with that, Afua. And I think when I think about the question, like, what can we do? I guess I think about it in a couple of avenues. And I think that one, it can feel a lot like, for me being a Black woman, it can feel a lot like being gaslit, that this is not brand new is the thing, you know? And every time someone's like, I didn't know, it can feel like you didn't know because you didn't have to know. And you want to know, right? And so we have all of this national research and state level research that says that racism is what's causing these birth disparities. Right. And we have like zero accountability for anti-racism education for clinicians. They're only in my class if they want to be there or if their boss makes them, right? It's not required. And so I think that's problematic. And I think that advocating for that, seeing all of this research that says that racism is causing Black folks to die, and then not doing anything about it, just being like, we should not be racist is the solution. That's not okay, right? It's not cute, it's not fine. And then I think the other way that I think of like what we can do to like create more, to address these issues collectively is like, think about how we're divesting from white supremacy in our own lives, right? How are we like rejecting, how are we acknowledging like that we're on stolen land, that our cures were bought on the bodies of Black folks, right? How are we acknowledging that? And then how are we like holding our complicity, right? We're on this panel with Planned Parenthood, and I am like so glad to be here, but I'm also aware of the fact that we did not call out Planned Parenthood's problematic history, right? And acknowledging our shortcomings is a huge part of being able to discuss them and remain in community when we have like conflict with each other.
Good one.
That was dynamic. And just to kind of like say a little bit, I feel like off of that, yeah, we should make people sweat. Right? We should be okay to ask those questions, and we should be okay to wait for answers. So there's a training, right, that I got when I started working here, and it's called the ask, right? So when you just like, all it is you ask a question and then you stop, nothing else, no distractions, and you stare at them and you be like, so I asked you a question. That's it, right? And we should be able to do the same thing. We should do the ask. Another thing, right? What's wrong with holding our elected officials accountable, right? They said they want the job, they got the job. So I'm gonna email you, I'm gonna call you, I'm gonna text you, however you wanna be reached. I'm gonna help find you and give you some suggestions to help do your job a little bit better, right? Because you're my representative and I want you to know about this. So we mentioned this a little bit earlier, I think on the second question, when we were talking about bringing in community, but centering is an actual program that exists, right? And it's shown to like improve birth outcomes, right? For folks of color, for anyone actually who uses it. And that is something we could actually be like saying, hey, you know what, elected official, I want you to put your name behind this. Find some dollars, right, to get behind these types of programming so people can use them, right? Absolutely, why not? And then another thing, if we're speaking, we're saying, hey, I want to be an advocate, but I'm not a part of like this particular community. Use your power and use your privilege. Sometimes there are some spaces we go in and people really listen to what you have to say because you're important in some kind of way. Maybe they know you, you're your friend, right? Or maybe it's your last name, or maybe it's simply just the way you look and present yourself. But go ahead, use that privilege and power that you have. If you see something that doesn't smell right, doesn't sound right, say something. Why not?
So one thing I would also add to this conversation, so many excellent suggestions. I'm taking notes on what you're all saying, is a shift in the narrative from racial health disparities to racism health disparities, right? So these aren't disparities of race, because that makes it sound like there's something wrong with the race. There's nothing wrong with the race. It's a process that's the problem. It's how people are being treated. And so that's a huge, huge deal that we need to be able to say, yes, this is happening, but do you know why it's happening? Do you know how it's happening? And not victim blaming.
Great, thank you so much for that dialogue and the information. Here's our next question from Ty.
Hi, everyone. Here's our next question. I'm Ty, he, him, his pronouns, and I'm from El Paso. So we have kind of a two-part question here. So first part is, what advice would you give to Black and Indigenous people of color in navigating the healthcare system in order to maximize their sexual and reproductive health outcomes? What tools or resources can they advocate for, or what tools can they use to advocate for themselves in this space? Afua, you're on.
Okay, yeah, okay, great. The first thing I do is to educate women about what the birth process is, what it actually is, because induction is when you're not even in labor and they're saying, okay, it's time for the baby to come out, and so we're going to give you some medicine to make it happen. And if the baby is not ready to come, then it's for naught, but they've already broken your bag. And then they're like, oh, well, time has passed. And so time has passed, so you have to have a C-section. My thing for women is you don't have to go. If they set you up for an induction and if they can't give you a reason other than, well, it's time, then don't go. If there's something the matter, okay, fine. But most of the time, there's not anything the matter. And women are expecting, they go into this system, the hospital system, saying, you know, I want a Maserati. I got my birth plan. I got my doula. I got all of that. And so I want my Maserati birth. But what they have in the hospital is a Ford Escort birth. And so it's very difficult to go into a Ford dealership looking for a Maserati. And so, but women don't know what it is that they're going into. And so, and I understand they don't have time to ask questions, or the physician, I had a mom tell me, she said, okay, I have 5 questions. And the doctor said, okay, I'll answer one now, and then I'll see you again next month. But then say, who can answer the question? If you don't have time to answer the question, who can answer this question for me? Do research about the doctor, do research about the hospital, because if that's where you have to go, then you need to be armed to the teeth with information about what happens. I had a resident ask, a OB resident ask one of my clients, he said, so you're having a baby here at the hospital? Because she was a lactation consultant. She said, no, I'm having it at home. He said, well, how are you going to go into labor? Like, he was an OB resident and he didn't know that you just do it it happens naturally. So if that's how they're being trained, then what do you think his practice looks like? But women have to know and be able to say, no, I'm not doing that. Because if there's nothing the matter, if the doctor cannot give you or midwife can't give you a reason why you have to be induced, because at the end of the pregnancy, everybody's tired and nobody wants to, because you walking, oh, I can have a baby now? Yeah, but they don't say, yeah, and there's a high incidence that you might have a C-section or you might even die. Because that really and truly, dying can happen anyway. But when you interfere with the process, you have a higher chance of not getting the outcome that you want, or being alive, or the baby being alive. Because nobody's guaranteed in anything anyway. But let's see what happens on its own. With a midwife. Oh, no, most of them go to a doctor, so go to the doctor.
I appreciate that. I got some good laughs in for today. I think, as we all know, birth has happened before any trained folks was present. So we must share wisdom. We must allow for time and space for that wisdom sharing to occur, whether it be centering pregnancy with its awesome outcomes. And so I think as far as accountability, as you all are participating in different kinds of systems, and including myself and institutional system, just an apology to our communities. I'm sorry. I'm sorry we're not able to meet your needs currently. I'm sorry for participating in a system that instills fear, changes the hormonal process that your body is supposed to have access to, that we know exists and had happened traditionally for so many years. I'm sorry for participating in the perpetuating of colonization in ways that benefit our systemic issues so that I can live in this capitalist society. There's intersectionalities to the amount of harm being done, and we participate in them daily. And so I think just starting there, I think we need to come to a place of apology. People shouldn't have to armor themselves to give birth. Let's just think about that. People having to do so much work to do something that is natural, but they're being prohibited from doing naturally. That's crazy. And we are all wrapped in it. Quite the entanglement, right?
Cool. Do we have any final comments on that? Are we good? Okay, we're actually running a little low on time here, so we're gonna have to skip the second part of the question, and we're gonna move on to the Q&A from our Facebook feed with Alex.
I'm here. I'm so sorry. I couldn't get it to get out of that little side cube thing. Hi, I'm Alex, she, hers. Thank y'all so much for being here. Okay, so the first question today is, how can women learn about the system? What kind of resources do you wish your clients had before coming in?
I guess I'll start that one. I want to acknowledge that we've used the word like women a lot in this call, and I want to acknowledge that like not only women have babies, and that like partners are also a part of this process. So I want to call that. And Asmara, I want to thank you for your acknowledgements before. They meant a lot to me as someone who's like continuously experienced violence in this system. I appreciate you. I think that like the way I got into this work is being so traumatized by birth that I like needed to prove something, right? And so as Black folks do, I set out to do that. And I ended up, I won't tell you that whole story, but I ended up having an unassisted home birth with my third and final child. And I brought myself very close to being like in harm's way in order to feel like I could do something that my body was made to do, right? And so I think that like my goal in organizing is to give access to that knowledge in like a community format prior to the first trauma, right? That's when we want to talk to like, that's why this panel is so important, because it's a youth fellowship. We want to like hear people and reach people before that trauma, right? We don't want our people to learn through violence. And I think that, yeah, one thing we can do is, you know, make it a normal conversation, talk about it as part of our normal, like collective conversation around our community and how we function and how we want to be, you know, spend time visioning with your people.
I think to piggyback off that, vagina, penis, titties. We need to get comfortable talking about this, not just in moments when they're being accessed by people we don't know. In communal spaces, there needs to be a shared understanding of the normal processes of our organs and also birth itself. And again, like it shouldn't be a person going into labor being the first time they've been at a birth. We should share these stories and experiences well before, and check in with your community. Like I love to geek out on this. I don't care where we are. We can have a conversation about it and we can go all the way. It's fun. So find your community folks who are interested. Get involved in different programs, but talk to your neighbor, talk to your mom, talk to your parent, talk to friends. Just engage in the conversation.
I think one more thing that I would say is that if you're a clinician and you're hearing this, or you're on the path to be a clinician, recognize that you're not being held accountable to the level of anti-racism work that you need to do your job successfully, and hold yourself accountable to doing that anti-racism work.
Okay, I just want to say thank you so much for that correction, like at the beginning, because that is so true, like making sure to use gender neutral terms. Okay, but the second question is, how do you measure impact in the population you're serving in each of your initiatives and services?
For me, that's an easy one, because a prime example, I had a mom, she was a first-time mom, and her sister had 3 C-sections. Her mom had 2 C-sections. So those C-sections, that even though she didn't have one, her whole pregnancy was, I'm gonna have a C-section, I'm gonna have a C-section, I'm gonna have a C-section. And so our prenatals talked about how the baby, at the end, I said, the baby's gonna slip out like butter. And that's exactly what happened. And she just had her second baby and it slipped out like butter. So the experiences that our clients have from even family members negatively affect them even before they have a baby. So these moms dying. So that leaves a hole. Babies dying, that leaves a hole. And so it is imperative that each of us do what we need to do to change the tide, because we are not healthy people because of the effects of bad outcomes from births.
I think also listening to people, and it's not always going to be by the survey method. As was noted earlier, these questions don't really get at answering true questions or getting to true answers, especially, I don't know, I just give an example. In the last year, I was talking about care provided in a place I was providing care. And I've been working directly with a Black community for over 2 years there now. And I'm hearing from people, I'm able to get into conversations and hear the harm that's causing today. It continues to happen. And there's people that tell me, well, we did a survey and people said they like the care. So just a reality check, like, yo, people weren't talking to you. They weren't talking to you. And it doesn't mean that people feel safe at all. That's even a little more scarier. You don't see that? But people be really blind to racism.
I think it's sometimes really funny how we try to like academicalize, that's not a word, everything. Like everything has to be like a qualification. And like sometimes my programs are like, we just be like tossing HIV tests in the air, like who wants one, you know, like do the thing. And sometimes like we create these barriers to access under the guise of like needing numbers and needing to be like to meet standards that no one is setting for us but us. And what our priority should be is like taking care of our community, right? Like I don't want to know what your average appointment time is. I want to know what you know about the people that you're like taking care of in the most vulnerable moment of their lives, possibly, you know, like I want to know a whole different thing. So I think that question is kind of also speaking to like, as a society, we have some shifting to do.
I think also like taking your resources that you have to the community that you want to serve, right? So we definitely have these methods and tools to measure, and I use what I'm supposed to because I'm at work. But since I'm at work and I get the liberty to choose where I want to teach, I head to those communities that look like me, right? Because when I was much younger, I didn't have that, right? I had a traumatic birth experience, one baby living, one not, right? And I passed through maybe, I don't know, umpteen medical providers before they realized, right? Oh, wait, that baby's alive, right? Let's do something now, right? So now we get that opportunity to kind of like empower these folks, empower communities, and say like, I want to help you as best I can, so you can definitely help you.
Okay, so I just want to thank all the panelists so much for all of your time and answers and knowledge. So I'm gonna pass it back to Hannah now. So thank you all so much.
Okay. Wow. Thank you all so much for this incredible panel. I know when we were putting this together, we made like a dream team list, and seeing our dream team here, like just absolutely incredible. And y'all dropped so much knowledge and so much wisdom. Wanted to close with highlighting how it's important to advocate for sensible healthcare policies in and out of a medical setting. Another way you can ensure public health funding is by giving to your community by taking 5 minutes to fill out the 2020 census. Even a 1% undercount can mean Texas will lose hundreds of millions of federal funding for the next decade. So please pledge to fill out your census today. We're dropping a link in the chat, and that is it for tonight. Thank you all so much.